So perforated bowel. So this is the worst case scenario where our bowel is stopped. Our bowel has maybe just perforated from battery intake, but we have an ischemic bowel here, right? We've got a decreased flow to that state, and now the bacteria have, kind of sluggish, have kind of proliferated, and the bowel has not, moved much at all, and now it's at risk for, the bowel integrity is much less, right? So it could cause easy perforation. And then you got the sepsis that's just waiting right behind there. All that bacteria has proliferated over time. Okay, it's always a surgical emergency. There's never a let's wait till morning, let's optimize them, let's medically optimize them. It's like, well, that doesn't mean anything. If they have peritoneal signs, it needs to have eyes by a provider to see if surgery is to get them fixed right now. If you have CT abdomen evidence, you have a CT evidence that you have a perforation, there's nothing to get around that. You can't just say, oh, we're going to try it later, right? Even if they're like on two pressors, two pressors is there because they're septic and because they perforated. If we fix the perforation, they're not going to be on the two pressors anymore, right? So it's like almost a catch-22, the chicken or the egg, which came first. And oftentimes we might get pushed back from surgeons, like, oh, they're on two pressors, they're not going to do good. It's like, well, they're not going to do good either way if we wait or not wait, right? So it's important to intervene as soon as possible. It's always a surgical emergency. Antibiotics, of course, right? It might help, but that's not going to help this perforation. Antibiotics don't fix holes. They fix the bacteria, and it's going to provide artillery. It's going to cause like napalm bomb activity, right? It's going to maybe help out, but it's not going to fix the actual perforation. The hole is still there. Okay, and then if they do go to surgery, it's called damage control surgery. And if they go to surgery late, it's a lot more damage control. There might be abscesses that have formed in the meantime, which worsens outcomes. They have a lot of contaminated material that we need to wash out of the bowel. All this bacteria that might have gooped out in there, we have to wash out with saline. You'll look at the OR report. They put like 4 to 6 liters of saline that they've washed out with, right? They may even spike it with a little bit of what's it called? Gentamicin, not gent. What's it called? Not neomycin. I think it's neomycin actually. They might spike it a little bit just to help out, wash out the whole deal. All right. So then they might defunction the gut, right? If it's really really bad, yes, they'll debride the tissue as well to take out this whole section right here and anastomose it together. Anastomosis is a fancy word of connecting, right? When I play with my Legos, like, oh, let's anastomose this one. Let's anastomose this one. It's the same thing, right? Except with the use of sutures. But defunctioning the gut, they might let the gut rest a little bit so that they will attach the gut to the abdominal wall, forming a stoma there. Sometimes they'll have the patient abdomen open afterwards. To me, that doesn't make too much sense unless they're going back. Oftentimes they just go back anyways, and then I'm like, well, is that a financial reason? I don't know. All right, so there's not unless they have a severe injury, like a lot of bowel ischemia, a lot of sepsis, that makes sense. But just like routine stuff doesn't make too much sense. And then colonoscopy. We talked about colonoscopy can cause perforation. All right, if it's a small perforation colonoscopy, they can watch it and monitor it, but definitely start developing peritoneal symptoms. What were the peritoneal symptoms again? They got diffuse abdominal pain. It's all the way through the abdomen. It's not just a splenic flexure where they damage they pop through the colon, right? Once it starts going from localized to diffuse, that's always a worst case scenario. That is a surgical emergency, especially if we know the mechanism of injury. All right, so appendicitis is a high risk for perforation. Diverticulitis, as we mentioned, not diverticulosis, but diverticulitis, causes abscesses and fistula and such. Crohn's disease, I mentioned, causes a lot of fistulas to happen. Peptic ulcer can eat through the mucosa down to the arterial capillary level and cause bleeds, but it keeps going, it keeps going, it keeps going. It's going to eat through the mucosal wall, right? So we have like our wall right here. We have blood vessels there, and then we have the peritoneum on the outside. And if we are eating through with ulceration, right? First we get a GI bleed, right? First you get a little GI bleed happening, and then next it's going to eat through some more, right? And it's going to start causing perforation into the gastrum. And you're going to have free air under the diaphragm, usually with perforations. So that's like pathognomonic. It's like a very, very high radiological evidence that you have a perforation. There's no other real good explanation for that. Sometimes you might see a little gastric bubble under there, and that might be what you're seeing, but if you see it on both sides, that's not a gastric bubble, right? There's a liver on the other side. There should not be any air over there at all. Right, so X-ray is a good way to figure out if there's intraperitoneal air. Sometimes it might highlight the bowels a little bit. It's very, very hard to see. That's why you want to get a good interpretation. So it'll highlight with like faint white outline, but you can't lie with the X-ray. We see that free air under the belly there, right there, or under the diaphragm, I should say. That's definitely a sign of perforation. And if they have peritoneal signs as well, that's definitely someone that needs to get emergent surgery. Okay, so perforation will lead to really bad outcomes if we don't fix it as soon as possible. All right, so post-op surgery. So what do you do post-operatively? This patient came back with a wound vac and an open abdomen. So usually, make sure they're monitoring drainage, making sure it's not changing colors. And, if they have an open abdomen, they have a high risk of losing a lot of volume. It's just like a burn patient when they're exposed to the atmosphere of the OR for a long period of time. They can evaporate a lot of fluid. The same thing when they have an open abdomen is a lot of fluid loss. So that you can expect them to get a lot of fluid. Now, it's a really double-edged sword. We got to make sure we're not causing fluid overload, because fluid overload is going to worsen outcomes. So we do want to replace fluids and pay attention to that, but we're not going to be overzealous, because when you get overzealous, you can definitely cause a lot more harm than good. All right, so knowing the estimated blood loss, what the I's and O's are there units on hold in case I do have a GI bleed? These are things I need to know to resuscitate the patient post-operatively. I'm going to monitor urine output and response to fluids, and what happens when are they still dehydrated, or did I give enough fluids? Because there has to be a certain point where we start pressors. And pressors are surgeons' worst enemy. They don't like pressors because now it's going to cause more ischemia of the areas that are getting pressed, right? Because we have norepinephrine, epinephrine, et cetera. These are causing vasoconstriction of the GI tract first, right? So bowel surgery especially, there's a high risk of further ischemia when we start pressors. When systolic blood pressure gets lower and lower and lower, we get risk for ischemic colitis, but also just bowel dysfunction in general. How do we avoid that? That's where trickle feeds can help, right? So trickle feeds are something we can do to keep the bowel alive, basically. All right, it's very rare to need TPN post-op. So someone comes back and says, oh, let's order TPN. It's like, did we assess them? I thought it was 7 days, all right? That's when you say, yeah, let's do TPN. If they know like they took out a certain amount of bowel, like I think it's like more than 35 centimeters or something, then yes, it makes sense. There are certain like clear indications when they have short gut syndrome, right? But other than that, if they anastomose the bowel together, right? They anastomose the Legos, and then did you not do a good job? I mean, I could feed them, right? So why can't I feed them now? So just try trickle feeds. That's the first thing we should be doing to try to get them to get the bowel working again, right? Because it may or may not be an NPO ahead of time, but ideally you want to get the bowel functioning and kick-started again. The best way to do that is with trickle feeds, and again, they're in the ICU being assessed every 1 hour even, and we can assess if their bowel is getting more and more distended. And then, oh, okay, well, let's turn that off. But you got to try. And no one's going to get better from starvation, and no one's going to get better from give increased peristalsis if you don't give anything to peristalse against. So that's the idea behind doing feeding. Also, the wounds are not going to heal, right? Mortality is going to be increased if we don't feed them. Okay, so is there evidence behind this? Yes, there's research and evidence about feeding patients with open abdomens. It's not like it's like, oh, that's a cool idea, let's try it. It was actually researched and studied that it is safe to do this with open abdomens. Now, are you going to get everybody to do that? Not always. So there's a we have to approach it with evidence. It's a good idea. Okay, so feeding held prior to ER, so that's not a great idea unless there's perforation. If there's perforation, absolutely, I don't want food going into the belly. But if pre-op, if they weren't like they have appendicitis so much, but like if they have like pancreatitis and they're going to pre-op or they have like diverticulitis but there's no perforation, they can be fed as long as there's no like actual mechanical obstruction that we noted, right? So, we have airway experts. We have experts that can manage this if it gets into trouble. Okay, and once anesthesia is worn off post-operatively, we can start feeding them. All right, that is perfectly fine. That is recommended. All right, so an open abdomen like this still can get some trickle feeding as long as the bowel is not discontinuous. If you have a bowel that is continuous, goes from point A to point B with no interruption, then that is okay. Sometimes they leave the bowel open in there and they'll go back the next day, right, to wash out some more and suture it back together. Okay, so here's a hemicolectomy on either side, and they might then make a stoma out of it to let the bowel get used to peristalsis and such, and then once it's good to go, they'll reverse the ostomy and put it back together again. All right, so abdominal compartment syndrome. So this is what happens when you have a distended abdomen. So belly that gets distended, and it could be due to, ascites. It could be due to trauma most commonly, but it could be due to just simple pancreatitis. We have increased inflammation in the belly. And remember, when we have inflammation in somewhere, it makes that somewhere leaky, right? So we have a very, very leaky gut or leaky pancreas. So if you have bowel infection, like a colitis of some sort, active colitis, and they're septic, giving more and more fluid is just going to make the fluids leak in those areas specifically. If that bacteria were to get into the bloodstream, yes, it'll cause body-wide vasodilation. But wherever there is inflammation, whether it be the pancreas or it would be the small bowel or large bowel, that is where all the fluid is going to be leaky the most. So in abdominal compartment syndrome, that is where you have all this fluid that you give them can easily leak into that bowel. Will blood products do it? No, but blood products are osmotically active. They will pull fluids, and we give fluids with blood products. All that stuff will then just deposit in the belly, especially if they have a GI sepsis, right? So that's going to increase our intra-abdominal pressure. If they're a neuro patient, definitely going to increase the ICP. As we know, the abdominal pressure translates to the thoracic pressure, which can translate to the intracranial pressure. Well, don't skip steps. Do patients that are septic or GI processes have trouble breathing? Yes. So that can increase intrathoracic pressures, increase the level of hypoxia, right? Increase PA pressures. That's going to put stress on the heart, decrease in cardiac output. And if you decrease cardiac output, I'm going to start compressing my vasculature, decreasing increased SVR, causing increased vasoconstriction, and that's going to cause decreased flow to my bowel in the first as well, and that's going to be a really bad situation, GI-wise, right? And then not only does all this extra increased pressure put pressure on the vena cava to begin with to reduce venous return to the heart, but it's also going to cause compression of these little structures behind the abdomen, the kidneys, and they're a high risk for decreased renal blood flow. And now you have an AKI on top of your abdominal process, and that's going to, and maybe in a sepsis process. And we know when you have sepsis plus renal failure, that's an extremely high mortality, right? Renal failure itself it automatically tags a 30 to 40% mortality onto someone's prognosis. Okay, so increases intrathoracic pressures, kidney ICPs, and kidney pressures. It increases kidney afterload. So increased afterload in general because the cardiac output's poor, but it also increases kidney afterload as well, right? Kidney, and also we got increased SNS activity, and we have decreased urine output, and now we have more toxins, and that's not going to help out someone that's trying to recover in the ICU. And again, who's at risk for this? There's someone with an abdominal process of any sort, right? Post-op surgery, that's high risk. When you have an open abdomen, some of the pressure can escape, right? But not all the pressure, so it's still possible with an open abdomen. Okay, so physical exam, like you say, oh, they got intra-abdominal pressure, that's high. It's only accurate about 40% of the time, right? You need to measure intra-abdominal pressure, IAP. All right, it's often overlooked, and if that's overlooked, you get a patient's kidney function gets worse. They start getting more acidotic because there's low flow to the gut, and that gets acidosis, lactic acidosis, etc. Low flow to the tissues, and that's all a downward spiral from worsening their outcomes, right? So reducing blood flow to the hearts, and that's not great, and that's going to reduce cardiac output, reduce blood flow to the organs in the first place, right, to your gut and to your kidneys. So all these things are affected. Liver tests don't stop working. They can have hepatic failure, right? We got decreased flow to our gut. We have immobility consequences. We got nausea, vomiting. If they weren't intubated already, they can be at risk for aspiration. Okay, and the SNS starts kicking in because our heart starts failing. They get decreased flow to the brain, right? And that's going to worsen their mentation. So all these things are things we want to try to avoid when someone has a bowel situation in the ICU. So what do? Our goal, just like with ICP, is get the pressure under 20, right? So goal IAP, goal intra-abdominal pressure, is get that pressure under 20, right? Well, technically, when you're more than 20, that is called that is ACS, or not acute coronary syndrome, but abdominal compartment syndrome. So we have a compartment that is enclosed. It can expand a little bit more than a brain can, because the brain is going to hit up against the skull. But you have this increased intra-abdominal pressure that's increasing. You're going to start compressing those kidneys behind them, right? and it's going to start decreasing flow to the heart, decreasing pressure overall. So we want to have a good, adequate pressure. Just like with the brain, if you have decreased pressure, it gets edematous. Same thing happens to the bowel, right? It's not going to get the flow it needs. It gets edematous. It starts shutting down, starts getting infectious, and now we have a sepsis on top of that. So it's called an abdominal perfusion pressure, just like a cerebral perfusion pressure or a coronary perfusion pressure. It's whatever's pushing back, right? We want to give it a certain flow, but there's definitely pressure pushing back on the other end. In the heart, it was CVP, or left ventricular pressure. In the brain, it was the ICP that's pushing back on the map. Here, what's pushing back on the map is the intra-abdominal pressure, right? So we want to have a good map of the belly, basically. Okay, so intra-abdominal hypertension technically is greater than 12, but greater than 20, that's where we have a situation where we have abdominal compartment syndrome, where the abdominal compartment is compressing so much it's reducing flow and increasing ischemia, and it's worsening our outcomes. So we got to be able to catch it before it happens. As we mentioned, physical assessment is only accurate about 40% of the time. So we have to assess, hey, is the abdominal pressure getting high or not, right? And again, it can still happen in an open abdomen. Is it accurate if the bladder doesn't work? No, unfortunately, so it's very unreliable. If they have pelvic packing or the bladder doesn't work, we're looking for the walls of the bladder to translate the pressure between the two structures, right? Just like pressures get translated. I chose lighter blue. There we go. So we're checking this pressure in the bladder, and that should be identical to the intra-abdominal pressure. There are such things where they can stick a little fiber optic needle inside of it to measure the pressure, but it's not accurate. So just like with an ICP where you stick a bolt in to measure the pressure is accurate, it's not accurate, unfortunately, with intra-abdominal pressures. So the best thing we got right now is to attach a transducer to it, right? You've got a hole in you, want to transduce it and get a waveform out of it. All right, that's what we're going to do. We're going to put a little pressure bag. We're going to lock into the Foley access port where you usually irrigate with. So we're going to go there. We're going to go ahead and clamp it right there. And we want a nice fluid column between point A and point B, right? We want a fluid column. What happens if there's air in there? What happens? You're going to have a reduction in your pressure, right? So you want a nice fluid column. So usually we're going to pull back about 14 mLs or so into the syringe there. And you can do it twice, do like 20 times 2, right? So times 2, about 28 cc's. All right, you can give a good flush in there. And you have about 20 cc's. Should be plenty to get a nice fluid column between the bladder and the transducer, right? And now we can get a waveform. And the best way to get a waveform is to have them supine, right? If you are sitting up, that's more pressure on the bladder. That's not going to be accurate. We want them supine is our ideal placement. And then the other piece, again, we've loaded up with fluid. We clamped the side over here, distal to the access point. And then the next step is they're supine, and we want this leveled at the level of the mid-axillary line. All right, so mid-axillary line is when we level it. You might hear some older folks say we're doing the pubic symphysis up top up there. Not accurate. Of course, the phlebistatic axis won't be accurate as well. Phlebistatic axis technically is when they're supine a little bit, right? Or sorry, when they're at 30 degrees, right? So you want them supine and mid-axillary line. That's our goal. All right, supine and mid-axillary is where the position should be. You got filled up with fluid, so we got a nice fluid column. You're gonna be able to see some respiratory variation. It doesn't look like anything spectacular. You're gonna see some respiratory variation. You're gonna grab the complex at end expiration, depending if they're vented or if they are spontaneous, right? If they're vented, remember vent for the valleys, that's where I have end expiration. If they are a patient, it's at the peaks, right? P for P. So it's the end expiration if they are is at the peaks if they are spontaneously breathing. They're on like a spontaneous mode of ventilation. So that's the idea. So we zeroed it, we leveled it, we got a fluid column, we transduced it, we got a pressure, and what's the pressure we want? Less than 20, right? Less than 20, perfect. That's what we want. If it's like getting around 12, 14, 16, we're getting concerned. We're going to try to see if there's anything else we can do. What can we do? We can evacuate intraluminal content. That means evacuating the bowels, right? So are they on a bowel regimen? Is there something we can do to disimpact? All right? There's even surgical disimpaction you can do. All right? Is there something else we can, so we're starting cathartics and such. Is there, is the wall compliance reduced? Is there like an abdominal binder in place, right? Is the bowel wall have a lot of edema in it? We can't really fix that, but we can diurese them, right? We can diurese them to hopefully reduce edema overall. And then, if there's positioning can help as well to help compliance. But optimizing fluid status, again, fluid overload is what caused this in the first place. So we want to cut down on fluids altogether. Fluid creep is a real situation where fluids start creeping from all kinds of sources, from tube feeding, from TKOs, from IV piggybacks that are 3 times a day. All these extra fluids can add up and cause it's going to go somewhere. And where's it going to go? Where it's the most leaky, which is the bowel, in a bowel surgery or bowel sepsis. Okay, so we can diurese them. We might need to do CRRT to pull off extra volume. And again, there's surgical decompression that can happen as well. They can do an open abdomen, they go back to surgery and open up the abdomen to allow it to expand. They can do a midline laparotomy. They just come in there and they just take a knife, go from xiphoid to pubis and just open up the bowel to allow it to expand. And of course, they're going to do that when the bowel is like over 20 consistently. And we've tried other stuff. All right, so surgical management. So we're being optimistic now. There's a patient who is getting better, right? What are we looking for post-operatively? What are some complications that might happen with any post-op patient, whether it be GI surgery or otherwise? I couldn't find another good section to put this in. All right, so routine surgery complications. What are you going to avoid immediately post-op? Post-op day 0 in the ICU is shock, right? So you ask him what? We're asking him how much estimated blood loss was there? How much fluid did you give? I gave 2 liters of crystalloids, 2 liters of LR in the OR. So that tells me I got maybe like 1 or 2 liters to work with if they get sicker, right? You always want to touch base with the surgeon to ask, hey, when do you want to start pressors, right? Because they gave 2 liters, I got 2 liters in the bank, or in the in the wings that I can give them, but after how many liters, right? They may be optimistic and say, I'll give 6 liters, 8 liters, but then you're going to pay attention to some of the fluid overload hemodynamics. Anesthesia can cause what? Cause, neurogenic shock, good. Cause hypotension, okay, is a side effect of anesthesia. And then hemorrhage is also a worry. Anytime you open up someone's body, you might not put it back together completely. So we want to make sure monitoring drains, making sure the output's good, especially if they got chest tubes, etc. And then what about post-op days 0 to 30? So that's the next 30 days. We know the ICU, we got to immediately recover them, make sure they're getting back to their baseline or wherever we expect them to be. By day 0 to 30, we think of the 6 W's right here. All right, so post-op day 0, you're thinking of waves. So waves being like T waves. So we have peak T waves that might occur. This is actually before this. You got peak T waves. It can be an MI immediately post-op. So if they take like a beta blocker beforehand, or they're a high-risk surgical patient beforehand, like a cardiac patient beforehand, we're worried for MI immediately post-op. And they can be what kind of symptoms? If they're intubated, they're not going to be able to tell you they have chest pain radiated to their jaw. They're going to have what symptoms? My SNS might still be firing off. They might have EKG changes. Troponins could be going up. They could have, worst case scenario, cardiogenic shock and a hypotension developing, right? So usually perioperative beta blockers help prevent this, right? So that's something they consider. We used to have a core measure that we made sure everybody who went to surgery that was on beta blockers got beta blockers beforehand. Okay, and then post-op day 1 to 2, we're thinking of wind right here. So wind is where we're thinking of a pneumonia that's developing. Atelectasis is happening, right? So atelectasis, ATX, could be developing with wind. And then we have water. We're thinking of what? We're thinking of UTI. So they have a UTI that might be developing day 3, day 4, day 5. The UTI is getting worse and worse and worse. This is why we consider taking Foley's out if we don't need it. Right? There's no contraindications. There's no urinary obstruction. The Foley should come out, right? And then now day 4, day 5, and beyond, we're thinking of VTE, right? So that's why making them walk, having SCDs the first 5 days is important, because day 4, day 5, day 7, that's really where VTE is going to show its ugly head. And then after that, after day 5, day 7 is where you start getting wound infections, right? So you got a wound infection that may develop. It might be superficial at first, but it can lead to a deep surgical site infection. Okay, so damage control surgery is a high-risk surgery, and they may need definitive repair afterwards to fix their whatever disruption may have happened. But if we have a normal surgery, that's these are the normal complications that might happen. But worst case scenario, they might develop worsening peritonitis. They might develop an anastomotic leak, right, where they have like friable tissue, like a cancer patient. It's very, very hard to sew their tissue together. It's literally like tissue paper that they're trying to repair their colorectal cancer with. So closure may be very difficult. They may need a stoma in the meantime, right? They may have washed them out if they're a septic patient, but fistulas can develop, abscess can develop, abscess as well. All these things can develop after a surgery that we have to be alert to. And there's signs, right? They got an anastomotic leak. If they're more than 350 pounds, you just operate. That's the end of story. You're going to operate if they're a bigger person. It's really hard for them to recover because of all the excessive pressure. But if they're less than 350 pounds, they may do like serial CT scans to make sure, is it just an abscess that's going to form? Does he kind of just put a drain in there? But if they start getting sicker and they're like in the ICU, they need to be intervened upon. All right, they're sick enough to be in the ICU, they're sick enough to go to OR to get intervened and get surgery to look to see how sick they are. On the floors, they may monitor them, and of course, on the floors, they start getting sepsis, you get surge response, they start more diffuse abdominal pain. That's a sign of what? We have diffuse abdominal pain. It's a sign of peritonitis. Okay, so peritonitis, you got abdominal pain. They might present with guarding, very, very tender, and it's going to cause a rigid board-like abdomen. Is very, very common. So over here is like the percentages. So pain, 100% of the time. There's not one person in this study that of a large amount of patients that did not report pain. Right? So it's not like, oh, you know, they might be on beta blockers, might hide the symptoms, or you know, they're diabetic, they might not have the symptoms of MI, just like every other MI patient. It's like 100% peritonitis, right? And then you can see guarding, and that's kind of with the pain, right? They're guarding, right? What does guarding look like? It's like we try to touch it, like no, right? That's guarding, right? And then tenderness as well is associated. And then we have rigidity as a board-like abdomen. So board-like abdomen with pain, diffuse pain, right? Fever is not always there. It's only 26%, right? But nausea, vomiting, distension is, you know, better than a coin flip, whether it'll be there or not. As with peristalsis, that's really on the floor where you'd be able to assess that, not really in the ICU. And the goal here is to look for where did it start, right? Otherwise, if it's diffuse, we're seeing, you know, is there something, you know, is it a surgical something that we can go in and fix that surgical piece that might be perforated? Is it a ischemic colitis, or is it something that's perforated from like Crohn's disease or diverticulitis? Or is it a SBP, a spontaneous bacterial peritonitis that happens with cirrhosis patients, which we'll talk about next time, right? So cirrhotic patients can easily develop a peritonitis from translocation of all the in that acidic fluid from the bowel into the ascites, and then it proliferates and causes a peritonitis to occur. And you can see here's a peg tube that has leaked, and all that stuff is leaking inside the gut, causing peritoneal symptoms. And a CT is going to be the definite way to determine if there's something going on. It'll find the leak for you, you'll see the free air, and we can then find the reason if we need to go to surgery or not.